Thank you, Chairperson. Initially, I'd like to thank my colleague Dr. Khanna who gave me this opportunity to be here and share some thoughts with you. Page up, page down. Now, coming to the radiation safety in vascular interventions, my first introduction to this subject was attending a unique mandatory course in UK, which was introduced, which we all had to attend to continue working in cardiac cath lab. My second introduction to the subject was in 1993 when I was handed over a punishment of 6 weeks by the radiation safety officer. And I had to go through a viva after 6 weeks to continue practicing as a cardiologist. Now, in this lecture, I had to read this subject after 16 years, and to my utter surprise, very little has changed in what we are supposed to do when I was taught in 89. But a lot of changes have come in the way the regulations are in the West, and there are new lawsuits. Now, sticking to the basic practice, if you look at it, now the dominant part in the cath lab is therapeutic work. That era of diagnostics is gone. So therapeutic work will give you more radiation. We are doing more and more tougher cases. There's huge expectation from the patients, from the hospital managers, and many of us have show-off factor. They like to record long CNAs to show off in various meetings. We are doing more complex and long procedures. And another main thing is that the same patient in a span of a year has to go through multiple procedures. Now, radiation injury is uniquely different from other forms of injuries. It's very localized. It occurs at subcellular level and our senses don't appreciate it. If your hand touches a very heated object, as a reflex, you will withdraw it. Same is not true for radiation injury. You will not perceive it. Damage is slow, goes on for years. And the classical thing is once it manifests clinically, there is nothing you can do about it, either to yourself or your patient. So these are very unique. These are the specific organs. Everybody talks about gonads. But remember the brain. Dementia is a complication of radiation. Please remember that. Cataract. Remember the other parts of the eyes as well. I would like you to remember that finger dose is cumulative and it will cause only one thing. You will lose that finger. That will be the first manifestation of finger injury. Please remember this. These are skin everyone talks about. It starts from 2 grays. Once the dose goes 12 grays, you are in trouble. So I'll bypass that. Why talk about radiation safety? It will prolong our occupational lives. And I'll just give you some idea about regulatory guidelines and avoiding lawsuits. Just one basic diagnostic angiogram gives a radiation dose which is more than 1,000 X-rays. In a cath lab, average machine uses more than 200 minutes per day. In a radiology suite, it's 2 to 4 minutes per day. And the radiologist or the radiographer is standing in a different enclosure, far away from the actual radiation field. There is no safe radiation dose. Please keep your mind clear about it. And since you will be reading many things in the literature, just to give you guideline, Americans use gray unit and British units use sievert. So 1 gray unit is equivalent to 0.7 sievert. And radiation dose to the cardiologist monthly is measured in millisievert. There are certain golden rules which have not changed in the last 20 years. The number one, reduce the dose to the patient. If you reduce the dose to the patient, then all the doses are reduced. You have to require the minimum number of runs. Think again before you take too many runs. You have to reduce the length of cine runs. It's not required to take long cine runs. You must develop a habit. Can I do this thing in fluoro? Develop this habit. And develop the habit, am I doing unnecessary fluoro? Just the 4 rules which have not changed in 20 years. In a standard procedure, the machine works 95% of the time in fluoro mode. And the fluoro gives only 40% of the radiation dose because the way the machine is programmed, the fluoro gives the less radiation. The cine runs account for just 5% of the machine use. but they give 60% of the radiation dose. So use the minimum cine runs and the short cine runs. Learn to archive the fluoro if you have to record extra image. There are many things like balloon inflation, stent deployments, and so many other things. You can simply archive the fluoro. There is no need to record the cine runs. In vascular work, you share like the coronaries, complex CTO and multi-lesion, but you are free from RFA and you are free from the LV lead placement, some high radiation procedure. In vascular work, there are certain advantages. Just think again, you don't have to use the machine in 12.5 frame per second, or sometimes it may be programmed not to your knowledge, it's running in 15 frame per second. But in peripheral work, if you think carefully, you don't need more than 7.5 frame per second. That's the classical. In peripheral work, you can work beautifully in 3.75 frame per second, if you know how to. You must develop a habit of planning your views. And once you develop this habit, if any of you have a radiation punishment, within few months you will realize that you don't need too many views. And very rarely too many views are required. These are the hard facts. And very rarely large number of cine runs or long cine runs are required. There is no need to continue cine run if there is no collateral filling. There is no need to see in every cine run the collateral filling to the full detail. There is no need for that. And once in few weeks you will need a patient where will you need to learn the cine in the venous phase or the levo phase. These patients are far and few, so leave this habit as soon as you can. Avoid the use of angulated view, because what happens is that II is moving away from the skin. The radiation, 2 doses. One the patient gets, second the operator and the nurses get. So once the II is moving away, the scatter radiation is giving more. So do not use prolonged angulated view. Avoid steep angulated view. The worst view is LAO-caudal. I don't know how many of you know that. Avoid working long, because then the beam scatter comes straight to your head, LAO-caudal. It will come straight to your head, the scatter. So learn to work in PA cranial or shallow RO cranial where the scatter is away from your head. But must remember that you are protecting your head, but there is no change to the patient. Patient dose remains the same. And avoid working long in the same view, because the patient skin gets necrosed, he is not going to leave you. There are more than 200 lawsuits in the West related to the radiation dose. Learn to collimate the views. Every machine has the virtual collimetry. Learn to use it. It's very simple if you just know how to use it. You can over-collimate in the PTA, PTCA wire and stent placements. And once you magnify the image, the X-ray dose is going to increase very hard. So magnification over is not required except in the final runs. You don't need that. I don't know why you continue to use it. Just think. You have to be liberal with wedge filters, because that reduces the scatter. And I repeat again, you have to think twice before you set the machine into the double magnification. Flat panel detectors cause less radiation. Any operator's body part should never come in primary field. You should plan a large room to scatter, to prevent the scatter of the radiation. And keep the large number of catheter shapes and sizes in your place, because occasionally there will be a patient you will not require prolonged. Reduce the time of the procedure, so reduce the dose to the patient. The more you move away from the patient, the radiation dose is getting reduced. If you use the shields, the radiation dose is reduced. Lead apron always wear double-sided, and they must cross over in the front. I think some slides are missing. They must cross over in the front. Always hang them or keep them at a curved parking place. Never fold them. If you have not seen the curved parking place, you can see ours and you can implement in your cath lab. Never fold them to keep in your cupboard. Lead glasses use is questionable. Must remember that. You must use this shield, must use this ceiling mounted shield which protects your brain and eyes, and learn to use this body shield. there's something patient specific. Some patients are more prone to radiation injury than other patients. Those who are obese, because machine goes into the high radiation. Those who have skin telangiectasia, so site of skin telangiectasia, when you have seen, avoid the stiff view in the skin where there is skin telangiectasia. Diabetics are more prone. Those with connective tissue disorders, they are more prone for radiation injuries. So my time is coming up, so I'll just leave these things. Oh, क्या सारी slide ही गायब है? कोई बात. But just very briefly, India, this is very sketchy guidelines. This is some British guideline. I'll view that some JCI and American guidelines have been implemented in some hospitals. Some machines have also latched up to. They give you the individual patient dose per procedure. The specific guidelines for pediatric patient and pregnant patient and staff. I'll just tell you, I've tried to initially add word in escorts, and here I made sure that lead shield is used. I'll just like to clear 2 points actually. Everybody asks you, why should we teach? When we teach, our radiation dose will be high. I've taught many people, must know that when you are teaching someone, please don't think your radiation dose will increase. Because that person is to your left, so A is giving you extra distance, and he is acting as a shield. So once you are teaching someone, you are not increasing your radiation dose. And I mean, I am very strange that 15 years ago when I started, my practice went up, then gone down to third of what it was. So if you are working in private hospital, don't worry too much about practice volume. Practice volume will give you unnecessary radiation as well. And I'll just end with this golden rule: reduce the dose to the patient, make it habit. The lawsuits will catch up with us also.